All right, good afternoon, everyone, and welcome to the March KPQC Learning Forum. I'm still just admitting there's a little bit of a lag in admitting people for some reason, but please put your name and facility in the chat. I will be monitoring that. I know we have a busy agenda today, so I'm going to go ahead and let us get started, and I'll continue to admit people, and I'll hand it over to Tara. So welcome.
Hi, everybody. We are going to fly through a couple of key items this afternoon, so we can get to our guest speaker. If you would for us, though, please in the chat, your name and your agency so we can take attendance, just like in kindergarten. This is important. Also, I've told you this now for 2 years, but I'm kind of a sports fan. So I know that a lot of my medical staff colleagues are too, and it's March Madness time. In obstetrics, that means a completely different story. And I'm well aware that that's happening across the state in many directions. So just tell us you're here today. We're really happy you took time to meet with us. And I promise it'll be worth your time for this next hour. Our agenda for the day is pretty simple because we've got some great content. I'm going to give you a really quick update. I think we owe it to the state and those that attend for just some debriefs real fast, an update on and some exciting advances on our general meeting coming up in May, and then of course our featured speaker. I also have a really exciting share, with permission, of course. Casey Sorrell and her husband welcomed their baby, Riker Sorrell, last week. He came a little bit early. She completed a meeting, her water broke, spent the night having a baby, and texted me first thing the next morning. So I think just like all of us, we have to pay attention that this group is made up of a tremendous amount of childbearing aged families. And when it's one of our own, it means a lot. Mom and baby are doing great. And now Casey is 4th trimester, and I'm checking in on her a lot. So just know that we're celebrating and aware that she's literally one of us. Speaking of births, I wanted to show off a little bit of the data that I annoyingly asked you for. 2021 data, it says 2022, but that's just to remind myself that this is the slide for this year. But the total births, including live and stillbirth in 2021 at our 28 sites was 26,000 births, 26,420 to be specific. And that's, again, over 74% of the births in Kansas. That means that amount of families are getting the information that you all are sending out through the 4th trimester project. And I'm really proud of you all. That's a great touch for so many families. Rapid response, I want, again, to share resources with you all each time we meet. These things will be emailed out to you. Tiffany and her team from KFMC do a great job of sending out the resources and the links to you after our meetings each month. And this one is brought to you actually through several avenues, including the Kansas Breastfeeding Coalition and Brenda Bandy, our colleague that does tremendous work with them. But the Every Mother Counts group has launched this phenomenal website and resource link. The website there is it's on the slide to the left. Again, you will get this afterwards. I would really encourage you to look through it yourself. Just like the other apps and resources I've sent, it's good for you to look at it before you share it, of course, with your clients and your families. But this is another solid resource for you all to link into. Again, it's really about the pregnancy, postpartum time, using parents as at the center of decision making. More magnets. All of you, I think, have gotten your post-birth second round of magnets. If you have not received them and your 4th trimester site, please email me today and I'll try to figure out where they are in the wide world of Kansas. But again, we want to make sure that you all have them in your hands. And again, are handing them out to patients upon discharge with education associated. On the 4th trimester side, for those hospitals and agencies that are enrolled, I've highlighted where you should be right now. Don't dissect this right now. Just take a look at it when the slide deck comes to you. For our champions specifically, I like to make sure you know where you are, where we're headed next. And in light of the general meeting coming up in May, the exciting, fast-paced movement that you all are making to change outcomes in Kansas. So again, take a look at that when it comes to you. Please make sure that you are completing those highlighted pieces. And if you're not, reach out to me. I'll help you get caught up. If you're ahead of that, and I know who you are, congratulations. You're the best practice models in Kansas. Just a reiteration of that conversation and a reminder that we've got a lot of free registrations left, 174 free registrations for post-birth on the A1 site. If you or your staff would like to get that individual CE credit, or it's just easier to hand them out versus do a group education project, there's plenty. Use them, but let me know. And so I can make sure that we don't go from 174 to 0 overnight. I need you all to be done, speaking of that, with your post-birth education, please, by the end of this month. We have additional coupons, not just the 174, but those are available through September for new and onboarding staff. So it's not like it's going to be closed as of March 31st, but we need to move on. We need to get everybody trained up. You can continue to train the trainer at your facilities, but it's time to move the process and the conversation and the expectation for standard postpartum education forward. So let's get that done. I'm going to pause and turn it over to my KCC colleagues. Patricia or Lindsay, are you on the call, and can you jump in and give us a quick update?
Hi, Tara. This is Patricia. Thanks so much. As the team knows, we've been working with a small group of sites over the last year or so to implement screening practices and participate in some small group TA. Over the last several months, you might remember filling out a TA needs assessment survey just for us to get a better idea around what some of the needs are. A couple folks responded to that they were interested in pursuing additional TA and were ready to start implementing. So a big welcome to those 3 sites. Thank you, Tara, that you've listed there, that will be onboarding as part of our new FTI maternal mental health TA cohort. And then exciting news, we're going to be launching a maternal mental health TA workshop series this spring, which you'll get a communication about this afternoon. So that'll be a series of workshops for our technical assistance sites to participate based on your feedback, to really dig into some of the processes we've been discussing around policy, around implementing screenings in your EHR, and other topics. So I'll be sending those out to the group so you know what to expect from those. But we're really looking for to have a skills-based learning opportunities and collaborative discussions. So this isn't going to be didactics where someone's speaking at you. This is going to be you guys learning from each other, asking questions, and then certainly there will be opportunities for us to share this back with the entire FTI group, as well as for the FTI sites who aren't currently engaged in maternal mental health TA to get access to some of those workshops. Tara, any other big things on the horizon you wanted me to mention?
No, I think you just nailed it, Patricia. I'm just going to smooth through again. They'll get the slide deck, but KCC is phenomenal at giving back information that you all have submitted. And I think for our sites, when they submit all these surveys and data points, you don't get to see it again. So KCC has included in this slide deck some really important things. Basically, how can we help was their question, and you all responded with great information, with great slides. I'm always impressed with their graphics. So we'll send those out as part of the conversation. And look at these goals that you all have set for yourself in 2022. When we're talking about staffing crises and we're talking about patient-specific outcomes, it is not lost on me that you're still setting goals and you're still making it happen. So kudos to you all, Patricia. Thank you so much to your team, and we look forward to the next step forward for everybody. As we move on to the conversation and the reason that we have our esteemed guest speaker with us today, I'm going to go back a second to this slide. The picture is eye-catching on purpose. Not only the age, not only the physicality of the 2 women, but it drew me in because I think, again, we're in this interesting transition in our world of COVID / post-COVID, but don't say it out loud, and what this looks like for the obstetric world moving forward. Having said that, really it's as basic in the fourth trimester of what we do at the time of discharge and bridging gaps of screening and referral to the outpatient side. Furthermore, on your radar should be this map is actually outdated. It's September of 2021 data, but it's a way for you all to see all the connections that are happening throughout Kansas, from what fourth trimester sites to KPCCs to MCH sites to all the folks from inpatient to outpatient that are linking in right now to make patient access and accountability of the providers more obvious. And you need to have on your radar what we're doing at the time of discharge on the inpatient or birth center setting that allows a patient to get the care and the follow-up that she needs. And what does that look like on the outpatient side? So it's all well and good to educate on post-birth, but what happens when she dials the phone? What happens when she shows up in your office? And what happens when she calls you on the postpartum unit at 2 o'clock in the morning, 3 days post-discharge and wants help? What does that look like next? So again, I'm not pushing you to think and move mountains overnight, but this is what's happening in Kansas, that good stuff, and time to move forward on that conversation. This is just, again, a list for you all to look at later of the groups and the sites in Kansas that are doing dual purpose work, inpatient to outpatient connections that are happening, and kudos to those folks too. So without further ado, I asked Dr. Birchie to come on. Actually, a while back, we talked about her getting some time in front of you all. I heard that she was doing some tremendous work at the local and state level. She's been on KPQC's executive committee for a long time. She's got a phenomenal resume. But quite frankly, I just wanted to her to talk real world to us in terms of what this looks like at Wesley Medical Center. What does this look like for her as an OBGYN hospitalist in terms of the first trimester projects that they're doing locally? And I think, you know, as we talk to medical people, please, and you'll see it in our slides, please hear the patient voice coming from us. And what does that mean? All these protocols and adjustments, but what do the patients need from us? And you'll get that from her. I'm excited to hear her speak. And Dr. Birchie, welcome. We're so happy to have you.
Thank you for having me. That was a great introduction. I appreciate it. So yeah, my slide, I don't have very many slides, but I just kind of wanted to talk about my perspective and some of the successes and challenges that we've seen trying to bridge that gap from inpatient to outpatient transition postpartum. Most of my involvement is on the inpatient side. So I, see the patient in admission, their delivery, their postpartum course while in the hospital, and then what the discharge process looks like. I get a little bit of the follow-up side with my involvement in the resident clinic, and we'll talk a little bit about some successes I think we've had at the resident clinic, and then the challenges of incorporating so many private practices in this fourth trimester initiative. So next slide, please. So this is just a refresher of what postpartum care used to look like and moving into what postpartum care should look like. I actually began my residency in this era of postpartum care where we didn't really think a whole lot about it. The exciting part was antepartum and delivery, and then postpartum, the patient was fine. No big deal. But as time has gone, we've learned that this is actually probably the most dangerous part of a woman's gestation, and that we need to pay a little bit more attention to how we're treating these patients, especially as our population becomes more complex, having a lot more comorbidities and things like that. So again, we're moving away from this old school one size fits all, single encounter at 6 weeks, everything's okay, thumbs up type of model to a more personalized model, which we'll see a little bit on the next slide. So again, this is just kind of the new school thinking, an ongoing process tailored to each individual. So in my ideal world, we would see those hypertensives and diabetics and those gals that are a little more complex, within 3 days to a week after their discharge. Again, between that week and 6 weeks, if they still need close follow-up, and then the 6 weeks and 12 weeks for a comprehensive exam. I just think it's really good to keep tabs on moms so that they know they're not alone. I did have a little time in private practice, and I remember several times how thankful and grateful moms were if the office reached out to them and just checked on them. And almost always they would have a question or a problem that they would need addressed and either come in or we could address it over the phone. So, just because there's silence there doesn't mean that there aren't things that we need to address. And I think that that's the important thing that we're kind of learning within this process. So move to the next slide, please. This is just a quick review of the AIM bundle that we're trying to implement. So again, readiness, having referral resources and communication pathways available and standardized so that there's a smooth transition from inpatient to outpatient, really incorporating a multidisciplinary team so that the patient gets a well-rounded care team, standardizing education, discharge summaries, and then trauma-informed protocols. I think this is just, again, something to keep an eye on and something we kind of have started trying to tinker with at Wesley, but just understanding there's a range of maternal mental health from perinatal depression to PTSD type symptoms from the birthing process. So next slide. And then this recognition and prevention, establishing a system for scheduling postpartum. We'll talk a little bit about some ways to hopefully bridge that gap. Screening each patient. So we do have a pretty robust screening process at Wesley, mostly because of our EMR, but I think our patients are screened 3 times on admission and the postpartum and then prior to dismissal. And then good documentation for these screenings and interventions and offering planning after the delivery process. Next slide, please. And then response and reaction. I really liked this picture because I think it's great. There is a difference between responding and reacting. In my mind, response seems more of a well thought out plan that was in place prior to, that is set up to respond to these situations systematically, versus reacting, which is just kind of a knee-jerk response that may or may not provide a good outcome. So I think that that's also important when establishing these processes. Next slide, please. So we'll talk a little bit about some of the things that we have been doing at Wesley Medical Center. We deliver over 5,000 babies a year, so we stay pretty busy. Some of our successes has been the standardized dismissal education. So we have a packet that we give each patient. It's standardized per patient. They get all the same information. The nurses give all the same information prior to discharge. We give the maternal warning sign magnets to each patient. And from what I've heard, the nurses love these. As soon as we ran out, they're like, we need more, this is great. So I think those have been a great success, and patients use them quite a bit. One thing that we have that I thought was really cool is the printable physician orders. So even if a patient doesn't necessarily understand, what medication they were on, because sometimes we have patients, especially hypertensive and complex patients, that will leave the hospital on maybe 6 medications. And so it's hard, it's hard for me to keep track of that for a patient, much less them. So having those orders to print and take to their appointments, I think is really important, even if they don't exactly understand what's on them. Some maternal warning sign flyers for when to call the office versus when to return to the hospital. Patients receive a printed copy of their discharge summary, so they get all the information from their admission through their hospital stay. Again, another piece of information that they can provide to their OBGYN or follow-up provider once they leave the hospital. And one thing I think we're still working on a little bit, but extension of this education to the emergency departments. Every now and then we'll have a patient come in, they'll be postpartum, sometimes, just a few days, but sometimes up to, 5 or 6 weeks, and they'll come in with severely elevated blood pressures or seizing, or things like that, or some sort of heart cardiomyopathy that doesn't necessarily get connected to the fact that they had delivered a baby just a few weeks ago, and that this change in them might be due to that rather than something completely separate. So really working with the emergency departments to recognize when an obstetrician needs to be notified and that their patient is in the hospital, I think is really important. And I think at Wesley, we've gotten a lot better at establishing that communication with our ED providers to where they feel comfortable reaching out and being like, hey, I have this gal of yours, she had a seizure, she's 3 weeks out, her blood pressure is a little high. I just want you to know about her. And again, manage her kind of more appropriately. On the opportunity side, we have a lot of employees, a lot of nurses, and that has made our education to the nurses difficult. I think the process, from what I heard from some of our nurses who undertook this, the process to logging in from home has been kind of difficult. It takes a while to get on. It doesn't work quite as smoothly as it works when they're in the hospital. And so some of the questions that have come up is if this education could be provided in a different format, like a health stream format, which is kind of our education format at Wesley versus, a slide deck or something along those lines. Also, our staffing crisis extends to Wesley. We have about a third of our nursing staff out right now in the women's hospital. And ideally, we'd want our employees to be able to work on this and not have to take time from home. We talk about burnout and we talk about moral injury and things like that. And trying to minimize how much they have to work from home, I think is important right now, especially as short-staffed as we are. But then they can't come to work and work on it because they can barely take a lunch, much less take extra time to complete an education piece. So, finding a way that we can work on compensation or finding time to help provide those education opportunities is something that we're trying to look into. Next slide, please. And then a little bit more on the patient follow-up side. One thing that I think would be ideal, my patient population tends to be more of the unassigned. So they come in, they don't have a doctor, or the resident population. And being able to find and establish a referral for these patients before they leave the hospital, I think would be huge. We don't really have that system in place right now, but if I had a patient that came in who didn't have a doctor, I don't see patients outpatients, so they do need an OBGYN referral. Sometimes they need a cardiology referral. Sometimes they need an endocrinology referral, and just having some place where we can put all those referrals in one and make those prior to the patient leaving the hospital so that they have that process in motion, I think would be huge and really help our compliance. These patients tend to be a little bit less compliant. So I think anything that we can do to help streamline and reach out to them more often than not, I think would be a huge win for this population. In our hospital, whether or not a patient's postpartum visit is made is dependent on the individual practices. So some practices will make a patient appointment prior to leaving the hospital. Most practices do not. They just give a time frame, and then the onus is left on the patient to make that appointment. So I think that that's a challenge, is that each hospital, we have over 9 different offices that have their own separate process on what works best for them. And then on top of that, over 40 OBGYNs, to get education out to find the process that works best for them and their patient population. And none of them are hospital employed. And as much as I hate to say it as a physician, sometimes being hospital employed makes it easier because you can say, this is our process, this is what we're going to do, and this is when you need to have it done by. But that's not possible here, for better or for worse. So just being able to establish those lines of communication and find a process across the board that works for everybody, I think is going to be a big barrier for us. And then I put a note that 2 are PSG employed, and what PSG is basically the HCA version of a doctor's office. So it's not necessarily employed by Wesley, but they're under the same HCA umbrella. So that's why you'll see kind of when we talk about the resident clinic is one of those where I think we've had a little bit more success in bridging that gap compared to a private office. So next slide, please. So again, translating to the outpatient setting, I mean, I pretty much have it made as far as counseling patients and being able to establish patients, because when in the inpatient setting, the patient is there, they're in the room, they're there with their baby, that you have their full attention when you're talking to them, and vice versa. All of your consults are in the hospital seeing the patient. So everything is right there in one spot, seen daily. So you have multiple resources, multiple opportunities to counsel the patient and talk with the patient, including case managers, nurse navigators, we have the standardized education. And so really on the inpatient side, that seems to make it easy. But then translating that to the outpatient side, I feel like we see a lot of this lost to follow-up kind of mentality, that we're relying on communication that's other than face-to-face. So phone calls, mail, email, portals, things like that. It's just not as effective as being able to speak to that patient face-to-face. So I think that that's a challenge in translating to the outpatient setting. Moms are tired when they go home. They don't sleep as well. They don't have as much help sometimes. They get confused. They have their appointments versus baby's appointments and who needs to go where, when. And it's just a lot to remember and a lot to take on. And then you throw some sleep deprivation and maybe some mood disorders on top of that. And it's just a very difficult combination to be able to have that smooth transition to the outpatient setting. And then I think, leaving the patient up to initiate that appointment or that connection really just adds another layer of another barrier that prevents the patient from following up. So next slide, please. So I wanted to talk a little bit about IRIS, and I think most people on this are probably familiar with it, but basically it's the state of Kansas has come up with this free referral tool, that's ran by KPQC. And we've started using this within Wesley a little bit and also within the resident clinic. And we've had actually a pretty decent amount of success in the resident clinic. So I want to go over that a little bit and then kind of where I would like to see this go in the future, at least for our facility. So when our patients establish at the resident clinic, an IRIS consent is given to all new OBs. They're automatically enrolled in Baby Talk. That's just kind of standard for our clinic. But we also give them a list of other options to select if they want to be referred. This consent is submitted and put in the patient's chart, and then our office manager automatically refers them through the IRIS system to the resources that they have chosen. Our office manager loves it. She raves about how easy it is to use. She says there's one place to keep track of all referrals and communications. The documentation is consistent. She said that we have a 94% acceptance rate, which I think is phenomenal, and a pretty short turnaround time, averages 6 days, but she was showing me most are like 1 to 2 days. You can see on there if the patient has been contacted, if a message was left, if they accepted services, if they declined services, and if so, why. So all that information is there. One, so you kind of know where your patient is in that process, but also if, on the other side of it, a patient says, well, I wasn't referred to this, I didn't get these resources. Well, you have that documentation in the system now. Well, yes, we called you and you declined these resources on this day. So you kind of on the flip side of that offers that documentation as well. And she said that you can send multiple referrals at once. So say the patient wants to be referred to 3 or 4 different places. You don't have to put a separate referral and separate information in for each of those facilities. You can do it all at one time and send it all in one go. So that's a huge time saver in my mind. You're not sending, 3 or 4 different referrals for the same patient. And you can attach records as well. So next slide, please. So again, this is kind of the good and the bad I see within the system. It's a great resource, again, free referral system for the state. You can use it to schedule your postpartum visits or specialty visits prior to leaving the hospital. That's kind of the vision I see, is if we could get all of our offices or the majority of our offices on this referral system, you can put your referrals in prior to them leaving the hospital. So you have that system going, you have that those referrals in motion. And I think that would be a great way to at least start to kind of bridge that gap in communication. Again, it's closed loop and you can send and receive referrals. On the flip side of that, you can only use the program if the office is enrolled. Currently, the resident clinic, the family practice clinic, I think 1 private clinic, and then maybe 1 other outreach clinic are enrolled for obstetrical services within this program. Most of the programs are more of the social aspects for like mental health, Baby Talk, resources, WIC, things like that, which is huge because our patient population really needs those resources. But I think if we could get those doctors' offices involved and enrolled in this too, we could see kind of that streamlined process translate over into the medicine like it has been done for the social side. Next slide, please. So just a little take from my perspective. I do think that this gap is bridgeable. I think it's a big gap, but if we get the right players in the room, I think it's bridgeable for sure. And I think those players, at least in our facility, are going to have to be those private offices. I think finding ways to minimize steps and maximizing the education that's standardized across the board is huge. And in my mind, our dismissal process at some point would become a package. So you can have your education, you can have your appointments, you know, if those appointments could be set up and referred before the patient leaves, and then they get a calendar invite on their smartphone. In my mind, that's great. I live and die by my phone, you know, and so if you have it there, if you forget about it, but check your phone every day, you see that that reminder's there for your appointment, and you can make those preparations. So a little bit on the prescriptions. We have an in-house pharmacy at Wesley now. They've been there maybe 4 or 5 years. And this has been a huge change for us as far as patients getting or having access to their prescriptions. A lot of times before this pharmacy was in-house, we'd have patients come back with high blood pressure, come back with blood sugar, poor blood sugar control. And they said, well, I just haven't had a chance to go get my medications, or I haven't got them filled yet. Again, because they're not in the hospital, you don't have them there to have that conversation. But now that we have this in-house pharmacy, those prescriptions get filled and taken to the patient's room prior to their discharge. And so I think this has been a real success as far as compliance for medications, is having that option to use the in-house pharmacy. And again, establishing that outpatient office follow-up and notifying OBGYNs if a patient does present to the ED, so we can make sure that that patient gets to where they need to be, gets the appropriate treatment. I had 2 kind of examples to elaborate on this. One just happened recently. I ended up doing a C-section for a family practice patient and went to dismiss the patient. And she had the standardized education for dismissal. She was getting ready to go home, and I was talking to her about, you know, what she needs to do. And you could tell she was so tired, and she had her baby there, and it was just her. And she got so confused back and forth between when baby needed to follow up, when she needed to follow up, where she needed to follow up, because she had the first part of her prenatal care at one clinic, transferred to a clinic that delivered, and then had her C-section done by a third clinic. So you could see how she was confused. She didn't know where to follow up. And so sitting down and having that conversation with her and writing it all out, that you personally need to follow up on this day at this office. Your baby needs to follow up on this day at this office. And again, just throw some sleep deprivation on top of that. And you can see how hard it is to keep all of that straight. She also had an infection complication and a hypertensive complication. So her follow-up was a little bit more complex than somebody who might have been less risk. And then the second patient example I have, I'll never forget this. I was in private practice and I had a gal, she was a teenager, so she was considered a pediatric patient. Went through pregnancy, did great, delivered a baby, did great, came back for a postpartum visit at 6 weeks and had been admitted to the hospital for peripartum cardiomyopathy and heart failure. And I had no clue. And I just, you know, that didn't feel very good, not having any clue that she was admitted to the hospital after her delivery for heart failure. But, you know, she was admitted to a hospital. She was a pediatric patient. So she was in the pediatric ICU, and there was just no connection there that I might want to be notified that she was there. And so again, you know, if my office had maybe done a little bit better job reaching out to her and being like, hey, how are things going? I might have known before her 6-week visit that she had peripartum cardiomyopathy. And there's a lot that goes along with that, you know, as far as contraception and future pregnancy planning, whether or not she can ever get pregnant again, and follow up to make sure her heart gets back to the functionality that it needs to be. And I just remember that blew me away, you know, that she had been in the hospital that period of time for that pretty severe complication, and I had no clue. So I just think tightening this process up would help some of those things. Next slide, please. So again, you know, the first way to all of this is engaging people and engaging others. And like I said, from my perspective, that engagement is going to have to be at the private practice level. and how we establish that line from the hospital to the private practice in a way that works for everybody. And again, continuing to work on our EG education. And I think honestly, from my perspective, pushing those offices to get enrolled in IRIS and having that opportunity to be able to start those referrals before they leave the hospital, and having all that documentation and follow up in one place, I think would be great. You know, even if you had a patient who was moving, say, they got their prenatal care here in Wichita and they wanted to move to Kansas City or Hayes or wherever, if those offices were both on IRIS, you could send those records, make that referral, and before that patient leaves your care, they have another follow-up established at their new office. So in my mind, that just seems super streamlined and efficient. Next slide, please. So again, I think I've gone over most of these, but you know, what's next in my mind? What's the direction we need to move? Again, a reliable process for appointment generation for each patient before they leave the hospital, and you know, maybe a technological way to make sure that they remember those appointments more than just a piece of paper. Getting the A1 education on multiple platforms so it's a little easier to use in different places, tailoring patients' follow-ups, and initiating those appointments and follow-up services prior to leaving the hospital. One thing I think that we can work on too, and again, this is kind of comes with that engagement to the private offices, and at least in my facility, is tracking patient follow-up and compliance. So is what we're doing working? You know, are we bridging that gap? Where are the holes? How do we fill those holes? And then making sure that we constantly are working to improve that process. And again, a way to notify providers on readmissions. And I think that this is a great start to incorporating reduction of peripartum racial and ethnic disparities. You know, this is certain populations are affected by this gap more than others. And I think recognizing that, identifying that, and then starting to incorporate how to decrease those disparities is really important. And I think that that's going to move us forward as well. Next slide. Okay. Any questions or even answers to some of the difficulties that we've been experiencing?
The chat is open if you want to enter your questions.
I got a shout out to Iris. That's great.
While we're waiting for folks to jump on, talk to us a little bit about how your own postpartum discharge conversation has changed over the years. Can you address that?
Yeah, I will be the first to admit that I probably was way down on the bar with my postpartum dismissal talk and education. I just, you know, we weren't trained in a time when that was an important part of the pregnancy experience. And I'd be like, you know, you eating okay, you drinking okay, you going to the bathroom, how's breastfeeding going? Great, you know, see you in 6 weeks. Call if you have a problem. And now, and you know, on the other side of that, when I was a resident, our patient population was, you know, the biggest BMI we dealt with was 40, you know, and now we have patients who have BMI of 60 and who have heart surgery and who have IVF. You know, you have a lot of women who are able to get pregnant now with a lot more severe comorbidities compared to when I trained. So our population is just shifting into a more sick, I guess, for lack of a better term, population, and being able to tailor that conversation to the patient. Hypertension is a huge one. I don't let a patient leave the hospital without seeing them within 24 to 72 hours for a blood pressure check. I say you need to come in. If you can't come in, you know, go by the fire department, come back to the hospital. You need your blood pressure checked. I think that that's huge to keep tabs on. You know, same with mood. We have, when we do our screening, if they flag on their postpartum depression screening, I say, you need to follow up in the office within a week. You know, here are the warning signs. If you start having any of these signs, I want you to come back to the hospital. If you start having, any feelings that you need to be seen sooner, please call the office and come in. So it's just a much more aggressive, I guess, counseling, dependent on that patient's comorbidity. And then a lot of emphasis on please call, come back, come to the hospital, or that's what we're here for. Don't feel bad, because a lot of moms feel bad for coming to the hospital. And just emphasizing that that's why we're here, and we want you to come in, and we want you to be healthy, and we want you to be safe. So, and that it is hard. I think that's the biggest thing I realized in private practice is how hard it is to be a mom, and I think our society puts this expectation on moms that they have to be a hero, superhero, do it all, not be tired, breastfeed perfectly, go back to work, able to handle babies when they cry, sleep, get good sleep, and be a good wife, and it's impossible and it's hard. And I think being able to tell moms that you're not alone and that it is hard and that it's okay that it's hard is really something that really kind of gives them that permission to reach out for help.
That's exactly what I was hoping you'd say.
Good.
I was taught as a midwife, I think, I don't know that it mattered or matters what your background is. I would say for our nursing colleagues, our triage techs, everybody, how we were trained was don't take your hand off the door. I remember specifically a physician telling me on postpartum rounds, don't take your hand off the door. What is that? What are we doing? So I appreciate that you're saying, the eyeball to eyeball look is important, and for them to hear you and listen, but yet us to hear them, right? We're listening to them more and more, which is huge. Other questions, conversation? I certainly, Iris is huge. I am listening to the A1 conversation so loudly. I hear you and I agree with you. I think all the sites probably wanted to say the same thing about it. And you were just the one that was honest, that it's really tricky to get this training done. So I appreciate your honesty with that. And I hear it constantly that that's a hard way for us to do that. But other conversation, I'd love for some other facilities or agencies to pop on. Certainly you're welcome to.
Are you able to see the message sent by Kara?
Yeah, about the recently
Discharge
merging
summaries?
the counties.
No, up above a little bit further, discharge summaries, are they routinely sent to prenatal care providers and primary care providers?
I don't know for sure that answer. I think it depends on the practice. I think some practices are set up to where they have access to those and that those are automatically sent, but I don't think it's 100% across the board for the practices. I know that the PSG or the HCA owned practices have access to it. They can just get on Meditech or Patient Keeper and have access to those. And I think that's how most of the other practices get access to them, but I don't think it's 100% across the board. We definitely could look into a way to try and streamline that. And then as far as I just want to make sure I don't miss a contact Iris. Yes. I will put my email address in there if you just want to email me, and our practice managers, I'm sure would be happy to reach out because she is a huge advocate for it. So I can connect you too.
Let me pop on here while you're doing that and tell you all that Iris has come up at the KDHE, KPQC level multiple times. And it is the link in to fix many problems. I didn't feed you that information. You just presented it perfectly, meaning that to me, it's an easy answer to the problem of the gap. And we've used Iris locally for several years. You're right. It really matters for those that are signed on to the system and those that aren't. And to go old school to a phone call in that scenario and paper faxing and all those things it feels backwards with those agencies that are not signed on locally. KDHE has looked at this to our 4 trimester sites to send it out to all the sites and have that availability. So know that that's been a conversation that we've had, and we probably need to revisit it. The link into the outpatient side, though, is the trickiest part of that if you don't have that linked in, for sure. Any other questions or conversation for our guest speaker before we move on? You also win for best graphics of 2022, by the way.
I can't take credit for them because it's like an automatic PowerPoint thing. So
I'm still rolling with, 1985 PowerPoint. So I think you're doing just fine, just fine. So before I let everybody go, and again, thank you so much, Dr. Birchie, for your time today and your advocacy on the Wesley / statewide push. I think your honesty about how you're still learning, as well as making changes at Wesley, is also profound. I think we need to be honest with ourselves about our own individual evaluation of what used to be wasn't working. So I appreciate that today. Real brief, I'm excited for our general meeting coming up May 24th. You guys got to save the date, and a little teaser on email about a month ago or so. More information is coming soon. I want to make it clear to you all that the guest speakers, the featured speakers at our general meeting, are in the morning session. It will be virtual for everyone from 9 to noon. And then the first trimester champions will be on site in one location for that virtual part. And then we will segue over lunch into intensive collaboration and some fun from 12 to 3 o'clock that day. So again, more information coming, but it is just the morning for the general membership for KPQC, and our first trimester champions will work in the afternoon together. The other exciting thing that I wanted to share with you is we've got 3 speaker groups, actually. Dr. Charlotte Smith, who is not pictured here because we just finished figuring that out, will be there for Kansas Birth Equity Network to launch our exciting training that we're going to do in 2022. But the other 2 folks that are listed here are make up the other 2 of the 3 guest speakers for our morning session. The Mama's Voices group, panel of 3 who are lived experiences survivors, patients that are now educators and advocates, speaking on behalf of birth equity, and phenomenal stories of survival and trauma and what they've done to change the outcomes across the nation. You'll be excited to meet the 3 of them. And then Dr. Pasha, you see his picture down on the right-hand side there. He has presented to several of you. In fact, you all brought his name to me almost 2 years ago as an implicit bias expert, has roots in Kansas, graduated from the University of Kansas, and now works in the Oklahoma area. But I'm really thrilled that he'll be speaking to us about implicit bias in Kansas and certainly throughout the nation. So again, more specifics on registration to come, but we're thrilled that the lineup is set, and we'll get that all out to you all. Finally, today, just a reminder, our next learning forum will be next month with information to come. We always send the registration link so you have it the latest one up to date, and we'll be sending that out in the next week or so. So thank you all for your time today. Appreciate your advocacy, and we'll talk to you soon.